right, we're live. Hi, everyone.
Hello.
It's Cassandra and Dr. Q, or Dr. Carollo, and we're here for another session of Ask Dr. Q Live. As Dr. Carollo mentioned last session, we are having a theme session this time around. So it's all about pain, sickle cell pain. And we got your questions on Instagram and Facebook. So we'll go ahead and jump right in and start asking questions. And please feel free to comment a question that you want to have asked on this session, or just give us a like if you like what we're doing. So we'll go ahead and get started.
I'd like to say also, if somebody has a topic they'd like us to have one session on, they should let us know. And we'll try to.
So we're accepting topics. So this topic, we wanted to start off with sickle cell pain first because it's such a big topic. And maybe this topic might need more than one episode because we got a lot of questions.
Well, it's a big deal.
Yeah, it is a big deal. Pain, of course. But yeah, if you have any topic suggestions, please let us know. You can send it in to ask@sc101.org or comment or, DM, and we will get that put into the list. All right, so we'll go ahead and get started. This first question here, is spine pain related to sickle cell disease?
Yes.
Yes? Okay, so problem with the spine, that could be sickle cell.
So you can have bone infarcts anywhere in any of your bones. In your, the most common places are your shoulders, your hip, but people have infarcts in their knees. Sometimes you have a bone pain in your leg, and if somebody does imaging like an MRI or something like that, because they're worried, they'll see you have a big bone infarct in your femur. Most people, if you have pain in your leg, people say, oh yeah, you're having a sickle cell crisis. So that's it. They don't really do any imaging.
They don't really know what.
Right. But if it was worse or really prolonged, they might do an image. So you can have infarcts in your spine for sure.
Okay. Now,
that is a little more of an issue than having a bone pain somewhere else or infarct somewhere else, because your vertebrae are very small. And in people with sickle cell disease, the vertebra actually collapse a little bit normally.
Oh, so what does that mean, that it collapse?
So your I wish we had like a whiteboard.
Oh yeah, so, we mentioned that last time.
So usually your vertebra are like little boxes. They're very square. But the blood comes in through a couple of arteries, and if they get occluded, instead of being square, it starts squishing in the middle.
Like concave?
Yeah, like concave. Sure. So someone can take a chest x-ray and look at it and say, oh wow, this person must have sickle cell disease or something, because they have these little concave. Areas in their
And that's because blood isn't getting to?
Right, so you're having little micro infarcts in your vertebra.
And can we actually define what infarcts is?
So an infarct is when the blood vessel, capillary or a larger vessel, gets blocked by the sickle cells. And so then no oxygen gets beyond that. And there's tissue. This happens everywhere. There's tissue damage, and your body's response to that is inflammation. So it sends all these cytokines and white blood cells into that area, but those inflammatory chemicals are what cause the pain. That's why anti-inflammatories like ketorolac and stuff like that actually helps the pain. Ibuprofen. In fact, it could, in some cases, it could be as effective as opioids, actually. So spine pain, spine infarct, spine pain is part of sickle cell disease. If the thing that you have to, your spine covers your spinal cord. So if you're having spine pain and you have any other symptoms like numbness, tingling in your arms arms or your legs or any other neurological, symptoms, that's a sign that you need to have it looked at, because there could be some impingement on your spinal cord.
Got it. Yeah, I was talking
issue.
about earlier. We were just talking about I have a bone infarct in my knee, and it's really painful, and maybe taking ibuprofen for the inflammation, because that's where the pain is coming from, is the inflammation. And I also take turmeric, and we have a post coming out this week on inflammation and green tea.
Absolutely.
Green tea is an anti-inflammatory, so just eating foods that I guess prevent inflammation.
Coumarin is one of the ones that actually has been studied, and it actually does affect inflammation and pain. So.
Yeah. What are the areas of the body where ones can experience sickle cell pain?
Well, everywhere there's blood, right?
Right.
So there are parts. So in order to experience pain, you have to have nerve endings that pick up the cytokines, what were just the inflammatory things, or they get damaged themselves. So there are places in your body where there are less nerve endings than other places. So like in your back, there's actually, in the skin, there's not that many nerve endings. But generally speaking, it's everywhere in your body you could have pain. In your nervous system, like in your brain, etc., in your retina, the back part of your eye where you see, there's no pain receptors.
So you wouldn't get pain in the back of your
So when
eye.
you have a stroke, you don't have any pain. There's no pain.
Okay.
You may have symptoms like you're just kind of spaced out, forgetful, or you can't, like you pick up a cup and it just falls out of your hand because you personally don't even realize that there's an issue because you're in the middle of having a stroke, but there's no pain involved. There is pain involved if you have an intracranial hemorrhage. So if you have, instead of having like a infarct that we're talking about inside the brain itself, if you have a hemorrhage and then pressure builds up, then that pressure can cause pain. So that's one of the questions was about migraines and headaches and severe headache pain. And so that's one of the issues. If you have really severe headache, worse than you've ever had before, and you go like, whoa, this is not what I'm used to, and you're sick to your stomach or having vomiting, those are related to intracranial hemorrhage. Very rare event, but...
And that occurs in sickle cell?
It occurs in sickle cell disease, Usually...
is that the name of it? Just intracranial hemorrhage? Is that the official name of the? Okay.
And it's rare, but it's life-threatening. So you really have to think about it if you're having a headache with vomiting or nausea, and this is just nothing like anything you've ever had before. So the other area of your body that doesn't have any nerve endings is your retina. So that's why, if you have sickle cell disease, you need to go see an ophthalmologist every year or two regularly to make sure you don't have retinal hemorrhages, because there's no pain involved with those either.
So you talked a little bit about nerve endings, and there's actually a question that we got that said, how effective are these treatments called transfusion or something like that?
I know
and what she said is, she said it is a psychoactive infusion to block the nerve signals in your mind for pain. So I guess it blocks the pain sensors, and it takes 8 hours in an outpatient visit. She asked, should I try it or should I wait for more research? They claim it's been around since the 60s. So I've never heard of that ever.
Oh, she's talking about ketamine.
Ketamine, okay.
So ketamine is a drug that has been around since, I don't know if it's the 60s, but a long time. And it's what's called a dissociative analgesic. So what that means is it's kind of like I don't want to say psychotropic, but it makes it so that you can actually be dissociated from your body. So you have like you imagine that you are outside of your body and you're looking down at yourself.
Okay.
So, and it's called a dissociative anesthetic or drug.
So it makes you feel.
It makes you like feel. I don't know, but it makes you feel very very weird.
Okay.
But it had, and that's. And they've used it in anesthesia because it also causes amnesia. You don't remember what was going on.
Oh, wow. Okay.
And it is an adjunct to anesthetic drugs and everything. So, but in pain or in depression now, they use it at a much lower dose than they would use in surgery. So and they usually, in sickle cell disease, it's used for people for whom opioids don't work very well. Okay. What she's talking about is in other chronic pain syndromes that are nothing like sickle cell disease. There's no inflammation, there's no infarcts, none of that happens, but they have chronic pain. They do these 8-hour to 72-hour infusions in the hospital. Okay. And it may be, pain is related to depression, and maybe those infusions kind of break this cycle, and those people with those other types of pain syndromes then can have no pain for months, 6 months, a year, whatever. But that's not, I don't think that is what would be going on with sickle cell. So in the emergency room, sometimes they'll use ketamine, or if you're in the hospital, and you're on opioids and they're not working very well, and people don't want to really increase the opioid dose for respiratory depression or whatever, they may add ketamine at a very low dose.
And it's safe within sickle cell, and you would advise, I think what she's asking is... I
think it's safe. I don't think it's been used a lot in sickle cell.
Why not? Do you know?
Because people didn't really... I'm not sure, I'm just guessing here. I think people didn't think it would be very effective because the pain syndromes that it is used in are not like sickle cell. Okay. There's no inflammation, there's no, they're just not like sickle cell, and people didn't think it would work. But when they use it in the ED, it's been shown to decrease the use of opioids, and some people feel like it was really, the patients feel like it's very effective.
I mean, from what I'm hearing, they turn off pain for months.
My only concern about it is used in very young children.
Okay.
Because it is this dissociative kind of medication. I think if you get it infrequently, it's probably not a big deal.
Yeah.
But in neonates and little infants, like in the ICNs and stuff like that, who are developing their brain, there are issues with using this drug with those small babies.
Yeah.
And kids' brains are still developing, so I'm kind of a paranoid person. So
yeah.
I worry.
I mean, rightfully so. All right, so this question is from Instagram from One Life Nick. If my blood work says my hematocrit is fine, but I'm still experiencing a crisis, what can I tell my doctor to make him more comfortable with giving me a unit or two of blood? And so first, can you talk about the significance of the hematocrit and what that means? Yeah. And then, does that mean if your hematocrit's fine, does that mean you can't experience a crisis? Or can you unpack that for us, please?
Yeah. So there's not entirely a relationship between your hematocrit and having pain. Although, if you have a very high hematocrit and your blood becomes viscous, like if your hemoglobin is 11 or 10 or something.
So can you tell what is hematocrit?
So the hematocrit is if you took your blood and put it in a test tube and then put it in a centrifuge, or even put it in a string and spun it around your head, you would realize that the red blood cells that are heavy are getting packed down into the bottom of this tube. And so at some point, you would have all the red blood cells packed at the bottom, and then you'd have the yellow serum at the top.
Mm-hmm.
In between the serum and the red blood cells, you'd have a little white line, which would be all the white blood cells.
Okay.
So the percentage of your blood, of that whole volume, that is your red blood cells, is called the hematocrit.
I see.
So like if your hematocrit is, say, like, I don't know, I'm thinking 30% or something
Mm-hmm.
like that, that's probably okay.
Okay.
If it gets really low, like if it's much lower than that, then you're having problems. Most people look at the hematocrit and the hemoglobin.
Can I say, is that the hematocrit kind of in relationship to how anemic you are? Because
right.
if it's lower, that means you're more anemic.
Right, that means you're more anemic. Same thing, it follows the hemoglobin. So if your hemoglobin is really low, like if your hemoglobin is like 5 or 6 or 7, then there's a relationship between the two. So if your hemoglobin is really high, so if your hematocrit is like 40% or something like that, that could cause the blood to become thicker, and you could have a lot of problems, but one of them could be pain. So if say you come into your doctor and your hemoglobin's usually 8.5,
mm-hmm.
which is kind of, and you come in and it's 7,
mm-hmm.
And you're having pain. Your hemoglobin goes down while you're having pain.
Okay.
You do have more hemolysis usually when you're having pain, but giving blood transfusions, increasing that hematocrit to 8 or 8.59 doesn't necessarily do anything with the pain.
So pretty much you're saying if your hematocrit is at a good level, you could still have pain.
Yeah, sure. You can have pain when you're on chronic transfusions.
Well, that was actually a question which we can get to
right.
later.
So anyway, so you come to me and you say, Dr. Carollo, I have pain, I want a blood transfusion. So what goes through my mind when you're asking about that? So number one would be, if your hemoglobin is already really high, you can't really give that much blood. It's not going to really make any difference, really. The second thing I worry about is one of the problems with people with African Americans generally, but sickle cell patients, is that you can make antibodies to the transfused red blood cells. So on the outside of your red blood cell, there are a lot of proteins and other things that are called antigens. And if you're transfused with a blood unit, a donated unit, and those red cells have an antigen on them that you don't have on your blood, then you can make antibodies to that.
Right.
And the first time, nothing really happens. You just make the antibodies. If you got another transfusion with that same antibody from a different person, you could have a hemolytic transfusion reaction. It may be really mild. It may just be your hemoglobin goes down a little bit. But at some point, if you make enough antibodies, then when the blood bank can't find blood for you in an emergency because you have too many antibodies. So
you said that was common, especially within African Americans. What's the correlation? Why?
Especially in sickle cell, because there's inflammation, and inflammation seems to be related to making antibodies to blood. So you usually give blood during some kind of a crisis event, acute chest syndrome or whatever, and the inflammatory response tends to bring up your, activate your immune system, so that increases your risk of antibodies. African Americans generally, especially in what's called the RH system, you have different, the RH is just more complicated in people with African Americans and people with sickle cell. And so it's more likely that you're going to make an antibody in the Rh system. And that was shown that, they had in Philadelphia, I think it was Philadelphia, they had a special blue tag program where only African Americans were done. Well, what they realized was the donors and the recipients both had Rh, unusual Rh patterns. And so they actually had more alloimmunization than if they had not used that program.
Oh, wow. Okay.
So the solution to this is to use, instead of using serology, is to use DNA to make sure that the testing, to make sure, and it's expensive, but it's available, to make sure.
You only have to do it once, right?
Right. You have to do it once on the recipient, the person with sickle cell, but then you have to do it on all the donors. Okay. Because you don't know what the donors are. And then once you do it, you only have to do it once on the donor too. So if you have a donor who comes in every 2 months, then you could set up a program where someone on a chronic transfusion, or you knew what everybody's genotype was, then you could have safe blood for everybody. That's expensive, but it's definitely worth it. And as things go along, it gets less expensive. So anyway, that's one of the things. The other problem is if you have 4 pain episodes a year, and every time you have a pain episode, you get 2 units of blood, over a period of years, you're going to become iron overloaded.
Right.
And because you're not on chronic transfusions, either your regular physician or other people are not going to realize you're iron overloaded unless they check your ferritin.
That's why it's important for us as patients to kind of track our transfusions.
Right, track your transfusions, and annually or something have a ferritin or an MRI to check your ferritin is spuriously increased in people with sickle cell disease. It's not a great marker, but in one patient, if your ferritin's going up for you personally, that means your iron level's going up. But overall, ferritin's not a good way to measure iron in people with sickle cell. So an MRI would tell you what your iron level was. So that's another issue with just kind of getting random transfusions because you have pain.
So to address these questions, is it possible to have a sickle cell crisis even with blood transfusions? The answer is yes.
Absolutely. So even if you have, if you're on chronic transfusions for some reason or other, stroke or some other medical reason, if you start, or somebody put you on chronic transfusions because you're having chronic pain. So you could still expect to have pain for some period of time. If you're having chronic pain and nobody's adjusting your medications or doing anything, you're taking the same amount of medications and nothing changes except for the transfusions, you might have fewer pain episodes, but you'd still have pain episodes. Even people who have a bone marrow transplant, if they have chronic pain, they get a bone marrow transplant. It takes 6 months, sometimes to a year before they're pain-free. And that's just because your body has to heal itself. Right. And there is this thing called neuroplasticity where you become sensitized to pain because you have so many pain episodes and you're on opioids a lot. And that's reversible, but it doesn't happen overnight.
It takes time.
Everything like that takes time. So yeah, you could still have pain while you're on transfusions.
And then, so what can this guy tell his doctor about, if his hematocrit levels are fine, but how can he kind of reason with his doctor and make him more comfortable with giving a unit or 2 of blood?
Well, the thing is, you have to realize that it's an individual thing, and so if he gets 2 units of blood and his pain just miraculously disappears, then he would have to sit. It's almost at that point you're looking at someone who's on almost like a chronic transfusion program, And the things I talked about, alloimmunization or the making antibodies, the iron overload, you'd have to sit down with your doctor and decide, is becoming alloimmunized, becoming iron overloaded, then having to take a chelator and have studies done. How does that, what's the risk benefit?
Right, you have to weigh out the pros and
all
cons.
stuff is like that.
Yeah.
And then you and your doctor have to sit down and decide, is this really worth it? Do you really, when you have a pain episode and you're getting, opioids and non-steroidals or, ketamine, whatever, and what's really making you feel better?
Yeah.
Is it the blood or is it the other treatment?
So what you're saying is you probably need to sit down and talk with
you need
his doctor, and
they have to decide together
if he wants to be on chronic transfusion.
When would I get a transfusion? Under what circumstances would I get a transfusion? How low would my hemoglobin have to be? I mean, if your hemoglobin is running, say 9.5 or something like that, you really don't want to transfuse people much over 10.
Right.
So you're not going to dilute out the sickle hemoglobin very much by giving a unit of blood to one, if you're an adult. So if your hemoglobin S is 95% or something like that, or 90%, and then you get a unit of blood and it goes down to, it doesn't go below 50, which it wouldn't, then that's not really affecting the sickling that
Got
much.
it. So then is there a way, because it sounds like his doctor may not believe him, so is there a way to kind of like say, well, here's a paper on just like, or how do you educate your doctor on that, and how do you start that conversation?
Well, you don't do it during a pain episode.
Okay.
So you make a special appointment and you sit down and say, I want to talk about my pain regimen.
Yeah.
And and try to figure out what is the best, when would you use transfusions, and so you both, it's just like your opioids or your whatever pain management plan. You have to sit down and work that out with the doctor, because he's going to be like me. He's going to say, wait a minute, there's all these side effects to getting a blood transfusion. Right. Is that really worth it? Does that blood transfusion really make a difference?
So that's the hesitation there.
Yeah, and I don't think there have been studies started to look at blood because it makes sense, right? Mm-hmm. To look at blood transfusions to treat pain in people with sickle cell disease, but there's just, as far as I know, there's never been one that's been completed where they've had enough people enroll and done enough transfusions to know whether or not it works. I can tell you that under one circumstance, so little kids who were at stroke risk during the STOP study who got put on chronic transfusions, those individuals, so they were really young. They were like maybe 5 or less. Okay. So they had no organ damage. It probably maybe never ever had a pain episode or anything. But because they had the stroke risk, they were put on chronic transfusions. Many of those, and I don't know a percentage, but they never had a pain ever.
Oh, wow.
Because they were being either exchange transfused or simple transfused, and they never, their sickle hemoglobin was always around, less than 50%, maybe 30%.
Yeah.
So that's an exception because they got started so young. So.
Okay. So in your experience, how long can somebody stay in pain for?
A long time.
So
that when you look in the literature,
acute. How about acute pain?
Yeah, so acute pain, you look in the literature, and Dr. Samir Ballas, who's like the pain expert, he has a little diagram he uses, and pain usually lasts at least a week or two. So that's kind of the average.
A week or two.
A week or two.
Okay.
That's kind of like the hospitalization. So you may be in the hospital for a week or two, and then when you leave, you're not like totally
No, you're not 100%.
pain free,
Yeah,
but you don't.
yeah.
You can go home and take whatever ibuprofen or whatever you take. So that's sort of the average hospitalization pain episode. But you know, if you have if you're on opioids long enough, and you can develop chronic pain syndrome in sickle cell disease, and so those people have pain a lot. You know, like when they've looked at adults with sickle cell disease, I'm trying to think of this percent, but it's a high percent. Over 50% will say that they have pain every single day for whatever reason. So do you call that a pain episode? Well, the patient might not call it a pain episode because it's sort of like their life, you know, I have pain all the time.
Yeah.
But a severe pain episode, being in the hospital, I've had people in the hospital, or I've known of people who have been in the hospital for a month or something like that.
Yeah.
The trouble with that is it's really difficult to treat pain over a long period of time.
Yeah.
Because after you've been on opioids for a few weeks, say, you can develop hyperalgesia, which means that the opioids themselves are creating a situation where your pain experience is worse on the opioids than it would be if they were started withdrawing the opioids or changing the management. The problem with that is, at the same time, other people could be developing tolerance, which means the same amount of opioids don't create the same amount of pain relief. So and the difference is that if you have tolerance and you increase the opioid dose, the pain gets better. If you have hyperalgesia and you increase the opioid dose, it doesn't do anything, or the pain even gets worse. And that's a really, really hard thing to deal with and I think sometimes people are hospitalized a little bit longer than they need to be because of this hyperalgesia. The other thing is, you're the patient, you're experiencing pain, and you're like, hey, I need more pain medicine. This isn't working for me. And you have to have a good relationship with your doctor and the treating physician, and be able to sit down and work out, well, you know, maybe we should change something. This doesn't look like tolerance to me. It looks like something else. Anyway.
Well, that's a topic that I think sickle cell patients get labeled with, you know, with drug seeking and whatnot, which is heavily documented that sickle cell patients are using opioids more so than any other patient population.
They're not using opioids anymore. The addiction rate isn't anymore. And they even have, there's a term that people use in sickle cell disease called pseudo-addiction.
Right.
And that's because the person is being undertreated and they're asking for more pain. You know, this isn't working for me. And the person, the ED, is like, oh, wait a minute, you know, you're taking more pain medicine than I've ever given anybody. I mean, I'm sure you've heard that.
I've heard that before. Like, this is the most I've ever given.
But you, because you do take pain medicine more than most people, you're tolerant. So you can take it. The issue with tolerance as well is there's a lot of side effects to opioids. One of them, the big one that people worry about, is depression. It's respiratory depression. And so if you are tolerant also to the respiratory depression and all the other side effects, because you have, the only thing that you're not tolerant with is constipation. Everything else, the more tolerant you get, the less likely you are to have the symptoms, except for that. So if you know the patient and you know what their opioid or their pain history is and what the treatment is, you can feel comfortable, like, oh, they always get 6 milligrams of Dilaudid or 3 or 4, whatever it is, and they're fine with that. But if you don't know that, then as the person who's doing the prescribing in an ED, they're just like, oh wow, what am I going to do if this person stops breathing, kind of thing.
Right.
That's why it's nice to have a pain plan that you've developed with your treating physician that you take to the emergency room with him signing it on letterhead, and you say, look,
Sometimes
you
that
know,
doesn't work.
this is what this is. Yeah, it does.
Yeah.
But this is
Sometimes
what
it's the person who's presenting it.
Yeah, this is what,
Yeah.
and here's the phone number.
Yeah.
You know, call them up and then talk to them, whatever. It's an issue. And it's a personal thing, you know.
Yeah.
It's like you're trying to negotiate with somebody who doesn't know anything about you or sickle cell. So that's the problem.
So, what other methods of pain medicine are there outside of harsh narcotics? They make me feel so bad and they leave me constipated with back pain. So what other ways, and that's something I'm interested in, is not necessarily, you know, it's so funny. We get like tagged with the stigma that we're drug seekers, but like a lot of us, like a good chunk of us, don't even want to be on this medication. Like it's the only option that we have is to take these narcotics or, you know, these painkillers. So I guess maybe it's addressing kind of like lifestyle treatments, or, you know, holistic treatments or natural remedies. What do you know in your, I guess,
well,
what do you know to work?
Yeah. I don't, you know, the trouble is natural remedies and all that, they really have never been studied.
They're not studied yet.
So nobody really knows for sure. You know, people will say, oh yeah, I took this and it helped my pain, but one person, maybe it did help that person, but that doesn't mean it's going to help everybody or the majority of people. So that's a real issue. So natural medications or natural herbs or whatever, there's not been enough studies to know whether or not they're really helpful in a pain episode, during a pain episode. But they can, you know, antioxidants, like there's a whole list if you go online of antioxidant foods that you can take, which actually are good for people with sickle cell disease. And just, you know, hydration, moderate exercise, etc. helps.
It is like a lifestyle thing.
It's a lifestyle change that you can't do it for a week. You have to really just change your whole life. The other thing is, if you have a bone infarct, so if you have like AVN or something like that, there's not really anything that's besides anti-inflammatories or something that's going to make that better. There are actually, well, I'm thinking about, you can actually get steroid injections in a joint that's really hurting, and that can take the pain away for a period of time. But, you know, basically lifestyle changes, if you're not on hydroxyurea, that's my kind of mantra, you know, if you're not on hydroxyurea, you should be on hydroxyurea. You should maybe add L-glutamine to that if you know, there's new drug, and there will be new drugs coming out that will help. But so I guess what I'm saying is you can do things to decrease or prevent the number of pain episodes, but once you're in pain,
there's not any natural remedy.
That I know of, there's no natural remedy that somebody who's in a pain vaso-occlusive episode that you can take that's going to work as well as opioids.
Okay.
And the weird thing about it is, I think I wrote this, is that even though there's this literal explosion of drugs being developed for people with sickle cell disease, as far as I know, nobody's working on a pain medicine that's like opioids without all the side effects, which seems like that could be something that somebody could, you know, that's not like an impossible thing to think about, that you create a drug. I'm sure there are people working on it, that you would create a drug that would interact with these pain receptors without the side effects of opioids. Opioids have been around for thousands of years, and that we're still using, it's the same thing they used, you know,
Back in
back
Egyptian.
forever.
Ancient
And
Egypt.
it's not, and they're not that effective. In reality, they're not really that effective, and they have some big time side effects if you take them chronically.
Right. Yeah, and then of course, we've talked about a little bit about this in the future, but that was a question that we had: is how effective is medical cannabis with sickle cell patients? And I know you mentioned that it's understudied, and so we definitely need more research around that. But in your experience, have you heard that? I think from what I've heard from Sickle Cell 101, it helps out a lot in sickle cell. Have you had the same experience?
I didn't have that many patients who were taking cannabis for pain. Most of the people did say that it was helpful.
Okay.
The studies that are being done, there's a big paranoia about cannabis in this country. So they're very tightly regulated, and you can't really make an equivalency between the study that's using one cannabis, whatever, the THC or whatever, and what you're going to get if you live in California. You can buy it,
right.
at Oaktown.
Yeah, we have that luxury.
So, and nowadays, I think the level of THC and cannabis is way higher. It's pretty strong.
Potent.
So you can't, even if a study says, this level of THC is not effective, say, well, that doesn't mean it's not going to be effective if you go buy some somewhere.
Yeah.
The issue with cannabis is, just like ketamine, it's a psychoactive drug. So if you use it a lot, it does affect your memory. Okay. So you can have short-term and long-term memory problems. It's psychoactive, and so you don't, it hasn't been studied enough to know whether it's really an issue or not. Mm-hmm. It's not regulated, so you really don't know how much THC is in the cannabis that you're buying. You don't know if something else is in it. Okay. I mean, so you don't really know what you're buying, really. And then there's also the idea that if you're smoking it, it's like smoking tobacco. It's not, if you have sickle cell disease, you don't want to be a smoker because you've already have issues with your lung function. And so what I told people when I was in practice was, don't smoke it. If you really feel like it's effective, then you should make some brownies or cookies or something. Mm-hmm. And if you looked at, I just read an article, I can't remember, and they were looking at these different things, and in studies, cannabis does not seem to be effective in sickle cell pain. But again, you just don't know what you're buying and what was used in the study. So.
Yeah. Okay. Somebody asked on Instagram if there's an alternative to ibuprofen. They're allergic to ibuprofen.
Ketorolac.
Ketorolac?
Yeah.
Okay.
So there are, ibuprofen actually, if you have asthma, can actually exacerbate your asthma.
Okay.
Yeah.
I didn't know that.
So, and if you, I don't know what her allergy is, but there is ketorolac, and there's not that many other there are other anti-inflammatories that may, they're all kind of related to each other. Mm-hmm. But it could be just the chemical of the ibuprofen that's causing.
What about like something like Aleve?
Aleve, I think, is ibuprofen.
Is it still?
Yeah.
Okay, I didn't know that.
Yeah, they're in low dose. Like when you buy it over the counter, it's 200 milligrams. And if your doctor prescribes it, it can be 400, 800.
Okay.
But there are alternatives to ibuprofen. And what you'd want to do is sit down with your doctor and figure out look at the chemical composition and see which one you might be able to take.
Okay. I have Kieran here who asked, can you talk about thalassemia therapy and awareness about thalassemia? And it,
what, is that the whole?
Yeah, so can you talk about thalassemia? I don't know what thalassemia therapy is.
Yeah.
Maybe, I guess, how thalassemia is incorporated with sickle cell.
Yeah, it's kind of, I don't, well, anyway, thalassemia therapy. So thalassemia is, you can have S-beta-0 thalassemia if you have sickle cell disease, but thalassemia
on its own is another
is a different disease. So,
okay.
And the treatment for thalassemia, depending on what type of thalassemia you have, and it's different from sickle cell disease in that clinically all the patients have severe anemia, but the genetic mutations, there's like hundreds of them. So you can have many, many different combinations and have severe anemia and need chronic transfusion. So in thalassemia, basically you are transfused every 2 to 3 weeks to keep your hemoglobin up, because you're not making enough or any. If you have beta 0, you're not making any hemoglobin at all. And so so that's the treatment, is chronic transfusions or gene therapy, bone marrow transplant. But once then the treatment for the transfusions is iron overload. So if you're on chronic transfusions, like most people with sickle cells every month or so, but people with thalassemia could be transfused every couple of weeks. They get a lot of blood, way more blood. Well, unless you're on chronic transfusion, but generally speaking, more blood than people. And they start earlier. They start when they're like 2 years old.
Okay. This seems to be a common theme. How can I get doctors to believe you if you're in pain, but the blood work comes back normal? So that is a very, very, very real problem. Like, doctors believing. What do? Do you hand them like a pamphlet that says, oh, here's a study on, why there's not a correlation between,
hemoglobin and
what is that conversation, and how do you navigate something like that? Because that's a real problem.
See, that's another, doctors can be really stubborn, but
to say the very least.
But I mean, that's another thing where even though it's not always effective, is that you have your medical history or a letter or something from your doctor on letterhead and sign that says, this person has hemoglobin SS with alpha thalassemia, and their hemoglobin is always 9.5 to 10. And they still have pain. And you hate to be kind of jerky about it, but you could just say, and there's no correlation, by the way, there's no correlation between your hemoglobin level and pain level. There's no blood test that tells anybody.
But is there something to substantiate that claim so that we as patients can have a better experience with the healthcare provider? Like, is there a pamphlet out there? Is there because just coming from our mouths doesn't seem to be enough. Well, so what can we do to kind of further?
Lots of medical literature showing that hemoglobin does not correlate. There's no blood test for pain. Hemoglobin.
Is there a study in particular that stands out?
I can't think of one off the top of my head, but I could find one if you want.
Is it in I don't know if it's in the NIH guidelines or
it's probably in the NIH guidelines. The ones that were the guidelines in 2014 were this evidence-based thing. So a lot of the recommendations are there's no evidence base for this, or it wasn't that it wasn't as convincing enough, even though to most sickle cell doctors they'd say, oh yeah, that works, etc. but there are definitely studies and literature in the medical literature to show that hemoglobin or anything, you know, that you do as a blood test is not going to tell you whether that person is having sickle cell pain or not. Even a low hemoglobin doesn't predict pain. I mean, some people just run really low hemoglobins all the time and they don't really. In fact, there was a study showing that if you iron restricted people with sickle cell disease and you made them anemic, iron deficiency anemic, they had less pain because the concentration of hemoglobin in each red cell was less. So the polymerization is related to the concentration, and if it's less, it just doesn't polymerize. I mean, that's not probably a good way to treat sickle cell, but it showed that the concentration in your red blood cell is more important than what your hemoglobin is, probably.
Okay. The last question I'm going to ask is kind of from when I've heard it been brought up in, you know, the medical community. They kind of just write it off with, you know, people are saying, oh, there's no pain associated with sickle cell trait. So I guess what do you know about, and there's a lot of people coming forward and saying, hey, I have sickle cell trait, I have all these symptoms, and they're all isolated people kind of describing the same symptoms. And so what do you know about pain and sickle cell trait?
Well,
and there probably needs to be a lot more research done on this.
Well, I think the first thing you need to do is, do you really have sickle cell trait?
Instead of
sickle cell beta plus thalassemia.
Okay.
Okay, so sickle cell trait is hemoglobin A, which is normal, and S together. And the A is always higher than the S.
In sickle cell trait.
Right, in sickle cell trait, like it's 60-40 or something like that. And in those people, at least theoretically, it may not be true, but theoretically, those people shouldn't really have pain unless, you know, you're really dehydrated or maybe you get sick or something with like a cold or like the flu. And I think that could definitely probably cause pain in someone with sickle cell. If they had the flu, they got dehydrated, they weren't having like hemolysis like, you know, football players and athletes with sickle cell trait get when they don't drink anything, or their coach just tells them, you know, run 20 miles and come back and tell me how you are, kind of thing.
Yeah.
But I think that could be an issue. But depending on where you got diagnosed with sickle cell trait, there are 14 different beta plus thalassemia mutations that are common in people with African Americans.
And Asian descent, right?
Right.
Yeah.
Just generally overall. But in African American, there's a lot of them. But in African Americans, there are 14 different mutations for sickle cell beta plus thalassemia. And so beta plus means you're making normal hemoglobin, just not very much, or not the normal amount.
Okay.
And so that beta plus could be anywhere from making your S beta plus be 70% of sickle cell and 30% of normal hemoglobin. That's kind of what people call, that's kind of the average. But if you have beta plus, you're still making hemoglobin A, but you're only making 2% of normal.
Okay.
Then you could have a hemoglobin S of 80% or even 85, and a hemoglobin A of like 15%.
And for context, can you kind of give what the percentage is of someone with sickle cell disease?
95%.
95%
If you have SS,
SS.
It's 95.
And 95% S and 5% A.
Yeah.
Okay.
Or F. It's probably F. It's probably fetal hemoglobin.
Okay, got it.
So
there are people with trait, it sounds like, that can carry a little more.
Well, technically speaking, they don't have trait. They have S beta plus thalassemia.
So they have two different traits. They have sickle cell trait, and then they have S beta plus thalassemia.
Well,
trait.
instead of, they still have, so sickle cell trait is AS.
Mm-hmm.
So that means there's more A than there is S.
Right.
Thalassemia, S beta plus thalassemia, is there's more S than there is A.
Mm-hmm.
So it's SA rather than AS.
Oh, I see.
Yeah.
Okay.
So
okay.
You know, so
okay.
as a generality,
Mm-hmm.
it's 70% S and 30% A. That's what, if it was on a test, that's
Mm-hmm.
what you would answer.
Okay.
But if you have a mutation, a thalassemia mutation along with the S, that gives you 10% A, and you have 90% S, then you don't have sickle cell trait, you have S beta plus thalassemia. And I think some people who, if you may have had very few or no symptoms as a kid, and as they get older, they have more symptoms because they really have S beta plus thal.
So is there a way that somebody can get diagnosed with sickle cell trait but really have?
Sure. I mean, it depends on where you got how you got diagnosed and where and whether, because what happens is you get newborn screening. Usually it's high performance liquid chromatography, and then that is confirmed in a lab, a reference lab, that you have, you know, S or SC or whatever. Mm-hmm. And I can imagine that if it was near the cutoff, you could be, the HPLC would tell you that you had sickle cell trait, and then if they don't send it to a reference lab, or the reference lab doesn't really put it together right, you could have S beta plus thal. And we had a patient who came to us who they said they had S beta 0 thalassemia, mm-hmm. but actually they had S beta plus thalassemia, and they only had 2% hemoglobin A.
Oh, okay.
So even though they were, because there was so little A there, it didn't get picked up on the HPLC.
I see.
And so something like that could happen where if you had, say, 10% or 15% A, it got picked up and somebody just said, oh, it's SA, or it's AS, or they mixed it up, and then you think you have trait, but really you don't.
So if you have trait, it'd probably be best, and you're experiencing
and you
symptoms,
have pain, then you need to be worked up.
And then you need to get
you need to have a blood test to make sure. There's also all different. There's the CORI, the Research Institute, mm-hmm. Children's Hospital Research mm-hmm. Institute. There is a hemoglobin called hemoglobin CORI.
Okay.
And that hemoglobin migrates when you do a test the same as hemoglobin A.
Oh, wow. Okay.
But it's a hemoglobin that actually sickles with S.
Okay.
It actually polymerizes with S.
Oh, wow.
And the way it was discovered, and this could be like, you know, if I was still practicing, I'd love to have all these people come and do, you know, figure out why they're having. So the reason why that was discovered was somebody had sickle cell trait and they were having a lot of pain episodes, mm-hmm. and they had splenic sequestration, acute chest. I mean, they were like, they had sickle cell.
I've heard, yeah.
Mm-hmm. And so when they actually sent the blood to the Children's Hospital Research Institute, you know, what is this hemoglobin? Mm-hmm. And they discovered it's a brand new hemoglobin nobody ever.
It's pretty much, we don't know what we don't know.
And so they named it hemoglobin CORI. And I think, I'm not sure, but I think the patient was in Canada or something like that.
Yeah, I've heard of hemoglobin Antibodies, which is like a severe type of sickle hemoglobin. So paired with A, mm-hmm. like you technically have sickle cell trait, but with that Antibodies, it makes it a lot more severe. So,
and there's a lot of hemoglobin. There's a lot of hemoglobin variants, they're not A and they're not S, that migrate when they look at these things. They look like they're A, but they're really not A.
Okay.
And so if you don't have somebody who really knows about how to test for hemoglobinopathies, I can imagine it could easily
get misdiagnosed.
Right.
So the standard test is the
HPLC.
Generally, which is the electrophoresis test, correct?
No, it's a high performance liquid chromatography. So
okay.
States generally use that because you can do a lot of samples in a big hurry. And if you have to test every newborn in California, you have to have a test that you just put the blood in there and it works. Then what happens is there's usually a confirmatory test, because there could be a mistake, the name could be mistaken, whatever. The samples could have got mixed up.
Yeah.
So when kids are, 2 months old or less, when they come to their first visit, you do a confirmatory test in a lab. And they also could do HPLC or they do gene sequencing if they really can't figure it out. Is this a hemoglobin that's brand new?
Yeah. There's
if you think you have sickle cell trait, or you've been told you have sickle cell trait, and you're having pain or other symptoms, someone needs to figure out whether you really have sickle cell trait or not. It's possible, to have sickle cell trait, I think, but nothing's impossible, but it would be extremely rare to have someone with sickle cell trait have pain.
Okay. All right. So you would just kind of ask your doctor, I guess sneaking in the last question, you would just kind of ask your doctor, what would you ask them in terms of testing?
Well, I'd say, I'd just say, I've been told I have sickle cell trait. I've never really been, I've never really seen the actual hemoglobin test. Can we just redo my hemoglobin test to make sure I don't have S with some kind of A variant that's causing me to have problems? I think that, that's a reasonable thing, and it's a lab test. It's not a big deal.
Okay.
Yeah.
All right. Do you want to give our disclaimer here?
Oh, yeah. So thank you so much for listening to us. And this, all these podcasts or live stream, they're not for diagnosis. They're medical advice only. So I'm like your dad, and I'm and I'm giving you advice. I'm not trying to diagnose you or tell you what medicine to take or anything like that. This is just an informational forum for people who want information. And if you hear something from me and you think, wow, that old man is really out to lunch, then what you should do is discuss that with your doctor.
Absolutely.
I think your doctor is the person who knows you the best. And, the things we've talked about, like transfusions and whether or not you should have a hemoglobin testing, that's information you take to your doctor and say, hey, I was watching this live stream and this old guy on there told us that maybe I don't have sickle cell trait. What do you think?
Someone said, thanks, Dad. Love it.
Well, you're welcome.
All right. Well, thank you all so much for listening.
Yes,
please give us
so
a thumbs up or heart. Please share if you find this information useful, and we will see you next month.
Bye-bye. Take it easy.